Good evening, everyone. My name is Marianne Peters, and I'm the CEO of the Carter Center. I'm delighted to welcome you to tonight's conversation at the Carter Center, Protecting Mental Health. This topic could not be more timely or important, and I think you'll be quite interested in what our panelists have to say. And I base that on the fact that I was privileged to have dinner with them earlier, so I'm sure you're going to be interested. Now, before we get started, there are a few things I'd like to go over with you. First, please silence your cell phones, but you don't have to put them away. I want to invite those of you in the room and those watching on Facebook and cartercenter.org to tweet about tonight's conversation using the hashtag Carter Mental Health with capital C, M, and H. Now, those of you watching virtually can submit questions to the panel via Twitter, or if you're here in the audience, you'll be invited to step up to the microphones that you see on either side to ask questions at about 7:50 p.m. Now, I'm sure you've noticed that we have a visual artist with us in the chapel tonight. His name is Matt Sullivan. Matt, thank you. And he will use his markers and his easel to document keywords and themes of this discussion. I think this visual depiction is a creative way to capture and document tonight's conversation, and we look forward to seeing Matt's magic markers at work. Now let's meet our panelists. Their full bios are on your chairs for those of you who are here in person, but for those of you watching online, we have Chuck Ingoglia, who is the Senior Vice President of Public Policy and Practice Improvement for the National Council on Behavioral Health. Chuck has played a major role in federal and state policy advocacy on issues relevant to behavioral health financing and reform. Wendy White Tiegreen also offers a unique perspective on protecting mental health. Wendy? Wendy is the Director of Medicaid and Health System Innovation for the Georgia Department of Behavioral Health and Developmental Disabilities. Wendy has 25 years of working in services, delivery, and administration in the public behavioral health sector in Georgia. And next, we have Sherry Jenkins Tucker, Executive Director of the Georgia Mental Health Consumer Network. Sherry is a certified peer specialist who previously chaired the Georgia Behavioral Health Planning and Advisory Council, the West Virginia Mental Health Consumers Association, and Legal Aid of West Virginia. As someone in recovery from behavioral health diagnoses, Sherry offers the critical perspective of a consumer of mental health services. And we are very fortunate to have journalist Andy Miller as our moderator. Andy has been a healthcare journalist for the past 25 years and is currently the CEO and editor of Georgia Health News. Andy covered healthcare for the Atlanta Journal-Constitution for more than 15 years, and he has won numerous awards for his reporting on hospitals, health insurers, state government, and Georgia's mental hospitals. You may have seen Andy's recent story on a report showing that there is a shortage of mental health services and professionals to meet the behavioral health needs of the children of Georgia. Now, all four of our panelists, that is all three discussants and Andy, are well known to our mental health program staff and are long-standing friends of the Carter Center's mental health program. And with that, let me turn the program over to Andy and the rest of our guests. I know we're all looking forward to this evening's conversation. Thank you.
Well, good evening. I'm excited to talk with our panelists about these important issues. I note that mental health is on the minds of people at the Capitol this year. That we have the governor's put in $23 million for children's mental health services, which is a terrific addition to our system. There was a press conference today about the unfortunate topic of teen suicide, which is a huge problem in our state and every state. And and of course we have the opioid crisis, which we know has mental health repercussions as well. So this is on people's minds, the people that are the power brokers in this state. So, so without further ado, let's talk about some of the issues, and then the big picture issues, and then we'll talk about some consumer issues. First of all, let's talk about mental health parity. This was a law that was passed, you know, in Congress, but we're not really sure how that's actually, is that really taking place in private health plans and in government programs? What are we seeing? Are we seeing parity in terms of mental health benefits versus other health benefits?
Well, I'd say if you think about, just look at spending on mental health and substance use disorders, in the aggregate, there has been an increase in spending. So it leads one to believe that more people are taking advantage of the benefits that are available to them. And yet, I think you'll hear from a lot of people that they still struggle with insurance companies to get the kind of range of care that they and their providers think that they need for their conditions. So I think, you know, I think the jury is still out, right, in terms of is parity working. And you mentioned, you know, the law was passed in 2008, but the regulations have actually just, you know, kind of been released and are just being implemented, both for the kind of commercial insurance carriers as well as for Medicaid managed care.
Why did it take so long, Chuck?
Well, so one of the congressmen who was very involved in the passage of parity comes from this family that nobody knows, Patrick Kennedy. And he actually has an institute that is about implementing parity. And he has a full-time person who kind of probably knows more about the laws and regulations and kind of the ins and outs of parity than anybody. And what he says is this is probably one of the most complicated federal laws he's ever looked at. And I think that's one of the challenges is, you know, the concept is really simple. Mental health and addiction should be treated just like physical health care. But then trying to make those comparisons ends up being really complicated because it assumes that insurance companies actually have written down somewhere how they make these decisions on the medical surgical side. And what we found out is that isn't always true. There isn't necessarily a process. So, so that's part of the complication.
I would add just a couple of additional thoughts from kind of a state administrator perspective. There are a lot of caveats in that law that then say, if this, then this may not be applicable. And so that becomes like a huge challenge for all of us as people who are seeking health care to figure out. So there's that whole dynamic with that. And then there are real obvious ways. Well, can you get 12 units of this here in the medical surgical and also get 12 units here in behavioral health? But then there's all the other dynamics of understanding how insurance plans apply certain rules for authorization and how they pay for things. Is that equal? So there's all of these dynamics that are kind of drill downs and drill downs to this law that make it extraordinarily complicated for folks to really understand how this is playing out for them in real life and to really try to figure out how to access what is needed in that moment. So I think that it's important that we all keep our eye on this because I think it is going to continually evolve and we are going to have to evaluate that and monitor that and have conversation about that on an ongoing basis for I think many more years to come to figure out how to really make parity fully actualized.
And I think, you know, part of the other part of that is, you it's going to be your state insurance commissioner who's going to be responsible for making sure the federal law is actually being implemented. And what they need are examples of insurance companies not following the law. And so they need individuals to file complaints. And one of the biggest problems we have around the country is that people don't file complaints. And I know because it's hard, it's difficult. And that is one of the big challenges. In New York, the Attorney General actually got very involved, and that was because there was a large number of complaints filed with their office, and then they actually entered into settlements with a lot of companies for violating the federal law.
Essential health benefits were established by the Affordable Care Act, and they work across private health plans, but they don't include recovery and rehabilitation. What can we do to kind of make that happen?
Well, I'd say, essential health benefits are kind of under attack generally, so will they even still kind of matter, especially in the insurance that's sold on the marketplace? That's going to be interesting to see how that plays out in state exchanges. But there's a lot of flexibility that the federal government gave, and I think people had imagined that the federal government was going to come up with a list of these are all the things you have to cover, and lots of people spent lots of time making those kinds of lists of this is what the benefit should look like for mental health and substance use. But then the regulators took a different approach and gave states options. And so what I would say to you is that how this has got applied in different places, it's highly variable, both in the commercial market. I think where essential health benefits has probably had a bigger impact is states not like Georgia, states that have expanded Medicaid. A lot of states have had to go back in and kind of look at their Medicaid benefit and add a lot of things to it. And so the big question is going to be, what's the future of essential health benefits going forward? Because it looks like the administration is trying to find ways to erode even the basics of it.
Sherry, when you work with recovering folks, do they get coverage either through government programs or private insurance for those services?
There's a mix of both, for sure, from the perspective of healthcare and more typical or classic mental health care. States like Georgia have done a very good job of supporting recovery and wellness and developing a peer workforce here. We have a large peer workforce in the state of Georgia, certified peer specialists that work with people to support them on their recovery journeys and actually are able to provide Medicaid reimbursable services. And those things are very, very important. One of the things that I think that we all need to do a better job of and is so important to this is to develop the relationships, to do the education of people who do not understand that recovery and wellness is alive and well and that we can and do recover. And I believe that with the current administration that we have, both at the federal level and at the state level, always talking about the reality of recovery and wellness not only saves lives and makes people's lives better, but it saves the system money. It's just the truth. I mean, I lived homeless and helpless in the backseat of an old car, and I run a statewide organization thanks to recovery and wellness. So it's true, it's alive, and it's well.
And you do a terrific job. I just want to add that. So we need to get the word out. People in the media even need to get the word out about peer specialists and what they can do in terms of people's recovery. All right, so Medicaid is a big program for behavioral health, obviously. And there's some talk, or there's some actually action amongst some states to require work for people to get Medicaid benefits. Now, that hasn't occurred here yet in Georgia. It might at some point in time. But what are some of the difficulties and pitfalls of work requirements for Medicaid?
Well, I can answer broadly and then let others answer. But states that are kind of Kentucky, Indiana, other states that have asked for permission to implement work requirements in Medicaid, those things didn't happen in isolation, right? They're part of a larger approach that these states are taking to require lots of other kinds of things in Medicaid at the same time. So they're asking, and let me just take a second to say, to be on Medicaid, you either have to be permanently and totally disabled, or you have to be very poor. And usually both things, right? You're in some states, the threshold for percentage of federal poverty is very low. So in this country, to qualify, the federal poverty guidelines as a family of four has to make less than $24,000. And in some states, the percentage of that you to qualify for Medicaid is like 50% of federal poverty. So you have to be making virtually no money. So states like Indiana and Kentucky not only requiring people to work, they're also requiring people to pay premiums. If they can't pay premiums to be on Medicaid, they're locked out of the Medicaid program then for a certain period of time. They're asking for increased cost sharing. States are eliminating non-emergency transportation from their Medicaid program, eliminating retroactive eligibility. And so all of these things together, I think, are just trying to make it more difficult.
So how does that affect the beneficiaries?
Well, the whole purpose of it, right, is to make people drop out of Medicaid. That's the whole purpose of these things, right, is to make it so difficult to comply that you're off Medicaid either for temporarily or for a longer period of time. It's no coincidence that last year all of the different bills that were called repeal and replace of Obamacare were really about changing the Medicaid program. And one of the requirements in all of those bills was that states had to redetermine Medicaid eligibility for beneficiaries at least once every 6 months. And the whole purpose of that is people are not going to be able to do it and therefore not comply. Now, I think most people with mental illness or substance use disorders probably want to work. And that's why we have programs that are funded in some states by Medicaid called supported employment. How do you help people get and maintain employment? And then there's complications, though, that come along with these illnesses, sometimes make it hard to maintain employment. And so the question is, do you want to encourage people or do you want to penalize people?
Talk about the supported employment situations, if you all could, and how they work and what benefits that can accrue to that person who has that opportunity.
Well, I will at least address it kind of from an administrative perspective, but then I really do want to hear my partners. Supported employment can be implemented through a myriad of fund sources. It can be done via Medicaid waivers. It can be done through state funds. It can be done through some collaborative partnerships with vocational rehabilitation agencies within states. But the value and the outcomes are so significant. And so really these are crucial rehabilitative services that are so meaningful to people because it gives them a sense of motivation and a sense of value and the sense of being a very productive member of our culture. And that is so impactful to these individuals. And so the more we can figure out the ways to make it available, more the better. I think the challenge is some of the more recent guidance related to states applying for waivers. We were hopeful that supported employment could potentially be included in a benefit. So when a state made application potentially for a waiver, that you could pair that with supported employment, right? If they opted for a work requirement to say, yes, well, let's put supported employment paired with that and allow individuals to have access for that for a period of time and grow into that rehabilitatively. And so I think that that's been a little bit of frustration recently with some dialogue and guidance from CMS, and I think it's going to take all of us educating all of our partners and constituents and legislators and advocacy voices in order to really begin to better articulate how meaningful that is as a productive assist to individuals, instead of it being kind of pushed off to the side as we talk about ways to reintegrate individuals into work culture and wellness and recovery. So Sherry, but this is very important for me to hear from you. Like, I want to pivot and say, tell me.
Well, I mean, it just goes without saying how important work is. I mean, what did most all of us do today? We went to work, you know. And it's something that adult human beings do. And not being able to access work has been very detrimental to so many of us, not just in the state of Georgia, but across the country. And so it's exciting to me to think about that there would be opportunities to support this idea of people who are on their recovery and wellness journeys, being able to access work and having the supports that they need to get, you know, the lift, the support to be able to move forward and keep going, but yet still be able to do things like access insurance, to be able to pay for care and treatment so that recovery and wellness can stay alive and well. And it's such a conundrum because you feel punished if you work, you get punished if you work, you lose your benefits if you work, but you can't make enough money to be able to pay for care and treatment or insurance or so on. And so it just, you know, it's the old hamster wheel. And so us figuring out ways to better fund supported employment and give people the lift that they need, the support that they need to have the courage and the skills to be able to move forward and live gainful lives. It's what's imperative for all of us, and it's what we all want.
Right. Wendy, let's talk about how the state monitors behavioral health services. Does the state at all judge quality of programs? Does the state license providers? How does that work? And just explain the various functions of your department and how it works.
Sure. Well, I could spend a long time on that, but I promise you that I won't.
I'll cut you off. Don't worry about it.
So there are so many different ways that the State Behavioral Health Authority does this. We have external contractors who help us go in as neutral parties and review providers, look at medical records. We do have prior authorization mechanisms where once the state establishes a benefit, we really want to have someone, clinical folks, looking at is this the right service for the individual at the right time? So we have partners who assist us in that process. We have data that we're starting to really get a good handle on. I mean, state agencies have not always had the technology, capacity, partnerships. We have now IT, information technology, I hate to use acronyms, sorry, information technology, connectivity with the Medicaid agency, so they're providing their data to us. We provide data to them so we can start looking at trends in healthcare usage within our system. We have not just state office employees who look at quality, but we have field offices who continue to engage in quality, do visits where people are receiving services. We have fabulous partners in our advocacy agencies who often assist us in doing consumer satisfaction and consumer surveys so that we again have parties who are not us, but engaging in that interviewing. And so we are, I think, nicely in Georgia positioning ourselves to get a much better understanding of quality. And the real challenge that I think is not just a Georgia challenge is ultimately how do we take that quality to the next step in terms of saying We want to buy the best services. We want individuals receiving service to be empowered by information that can be in the public domain. We put our quality review scores. So when agencies provide services for us, we have our scores online, transparent to the public. And how do we take the next step and provide better quality information to individuals seeking services so that they can make informed purchasing decisions and say, I really want to go here because of the quality of service. So those are the things that are kind of our next wave of really exciting production, I think, for state and federal agencies. And we're working pretty closely in terms of state authorities with trying to inform our federal partners, such as the Centers for Medicare and Medicaid Services and the Federal Agency for Mental Health and Addiction, on how we can do that together. And so that is, I think, a pretty wonderful next phase, but there's still a lot of work to come with that.
Chuck, how does that shape up with what's happening on a national level?
Yeah, well, let me just maybe take a step back, Wendy. And I'm guessing all of that great work that you guys are doing, that's for providers that are funded by the state, right, to serve people who are mostly indigent.
The state and Medicaid.
State and Medicaid,
yeah,
but
state
yes,
and Medicaid,
but right.
Yes, public.
And so I think one of the interesting things, and I don't know, how much people realize this, is that in this country, people with most serious mental illnesses have been served by state authorities for a very long time. It's kind of been a state responsibility, and all that work that you're focused on is really on those providers who are being subsidized to serve people with more serious mental illnesses. And then we've got all the rest of the people, right? We've got all people who have private health insurance who seek services, and there's really nobody kind of looking at that, right?
Well, do insurers do anything in terms of steering people to, let's say, quality providers? Does that happen? Does that not happen?
Well,
enough?
I think the question we have is, what is a quality provider? And I don't, we're an interesting field. We probably have more outcome measures, tools, than other parts of medicine, but I think part of our curse is we have all these different tools. And sometimes within the same state, nobody uses the same thing. And, let's take a step back. Do we have a healthcare system in this country? We don't, right? We have a whole bunch of autonomous kind of people doing things, and so there's nobody in charge. And so I can't really answer your question about nationally what's happening because nobody is really looking at this nationally. I can't even tell you within the public mental health system what's happening. We have no data even about that.
So if you look at one state, you look at one state.
Correct.
Yeah.
And you look at one
right.
state's public mental health system.
Mm-hmm. It's just a subset. Good point.
All right. So let's switch gears and talk about some consumer health issues here. If someone is, how does one know if someone is experiencing a mental health problem? And what does one do if that's the situation that's occurring?
Well, certainly from where I sit, lots of us know when we're having challenges and can seek support if there is support available to us. One of the big things that we do in our world is, of course, offer support. There is a lot of work that we do with supporting people with developing plans like wellness recovery action plans or those types of self-directed tools to support one with getting what they want and need through their recovery journey and when they're having difficulties and crisis. We have programs like Mental Health First Aid that train communities to learn about how to support people to be able to identify and support people when people are going through challenging times.
What if it's a friend? You notice a friend in this situation who looks like he or she is having a problem, or if it's a family member, or even a fellow student? I mean, what should one do? How can they have a conversation? Should they refer this? I mean, what's the best practice there?
Well, yeah, and I think that was like a great launch, because Sherry led by saying many of us know when we're experiencing symptoms, and because of long-term stigma, many people don't know. And so I think the more each of us in this room will talk about mental health, we'll talk about addiction issues, we'll engage with people, in terms of saying, how are you? What are you feeling? How's it going for you today? How's it going for you over the last month? Those meaningful, caring conversations open these doors where you can then start exploring. And I mean, I think so much of it is in society, we've had decades of not talking about this. And so we're not the greatest with our skills. And so we're here tonight because we have some interest, passion, care about behavioral health conditions. And so we are probably much more equipped than many, many others. The more we can talk about it, the more we can encourage others to talk about it, then it generates more and more dialogue, more and more empowerment, more and more knowledge. And then, of course, then you have to find the resources. Okay, so now we've identified it. Now where do we go? Georgia has had the benefit of, since 2006, having a relationship with a statewide Georgia Crisis and Access line. So we have a toll-free number. It is staffed by clinicians and experts in crisis and access, 24/7, monitoring the phones, picking up the phones, great technology support with that product. But many people still don't know about it, even though it's been more than 10 years. We talk about it, we market it, but many, even of my friends and family, don't have a card in their pocket. So we have to kind of talk about all the places and spaces where folks can turn and really figure out how to jumpstart these conversations towards health.
And it's important that we're not afraid
Right.
to have what might, when you're standing back looking at it, feel like a hard conversation. But conversations that grow out of care and love are ones that are worth having. And I'm telling you, some of the best work I've ever done in my life is when it felt like someone was in danger from themselves, asking, are you thinking about hurting yourself? Those things can save lives. They feel scary, but it's important. And when you're in trouble, having been a person in trouble myself, having someone express love and care really matters. In addition, here in Georgia, we're fortunate that we have various types of services and supports. And in addition to the Georgia Crisis and Access Line, we also have warm lines here in Georgia that are run and staffed by various varieties of certified peer specialists, including certified peer specialists and certified addiction recovery empowerment specialists. Both the Georgia Mental Health Consumer Network and the Georgia Council on Substance Abuse both run warm lines that people can access from all over the
What's
state.
a warm line?
A warm line is where someone can call and get peer support over the telephone. And people can talk about what's going on with them. They can seek, information referral about resources, and have a conversation with somebody who has been there and done that with their own version of having difficulty, and be able to support someone through a rough time back onto the recovery and wellness path.
Chuck, you've been in this field a long time. Are these conversations happening more than they did, let's say, 10, 20 years ago? Are people more comfortable talking about these issues?
Well, I think in general, most of us would experience from our own personal lives that people are more comfortable talking about mental health issues. I noticed my own family and friends, that it's a lot more common. But I think about, Sherry talked about mental health first aid. This is a program that's not that old. Was created in Australia, brought to the United States just about 9 years ago. And already more than 1 million people have been trained in mental health first aid. And
Tell us how it works. Tell us how.
yeah, so it's a course that tries to teach you the signs and symptoms of mental illness and how to have a conversation with somebody if you think that they're experiencing a problem. And it kind of teaches you the basics of the most common mental illnesses. The most common mental illnesses are anxiety and depression. And then it also covers psychosis and substance use problems. And then how to have a meaningful conversation based on empathy and support. And also local trainers that also know about local resources to tell you, hey, if you think you're having a problem, this is where you can call. And the cool thing about it is that it's for anybody. In different parts of the country, librarians are taking mental health first aid, police officers, firefighters, people who work on college campuses, people who work in high schools, churches, just so that they feel comfortable. We actually run a class every year for congressional offices. They want their front office staff to go through mental health first aid.
What happens, though? What are the major reasons why people who need care don't get it or don't want to get it? I mean, this hits home with a family member of mine, just doesn't want to get the care that we think would make him more fulfilled in his life. What are the reasons for that?
I say so respectfully to a media person that I really like a lot and have always admired. Look at what the media portrays about us. It is so often, I turn on the news in the morning and I hold my breath, fearful that the first story about the latest shooting is going to be about someone that received care for depression in 1978 or whatever. We are brushed with this broad brushstroke that makes many people afraid of us, that we're dangerous and that we're loose cannons and that you have to be afraid of us. And so it's so difficult when you realize that your brain maybe isn't working as well as you want it to, and you're having difficulty. It is so fearful to admit this because discrimination, stigma, it's alive and well about us. And it really is a deterrent.
Absolutely.
Well, I would also say I think that's true, and then also that I think that what's often come along with that, right, is a sense of hopelessness, that there is not a solution. And I think
a life sentence.
The work that you're doing to show that recovery is possible is really important, that people can recover from these illnesses and lead meaningful lives.
I would just add one other thing is I think when you were talking about quality monitoring, there are not, the behavioral health field has been behind other sciences because of stigma. And so I think that the more research is done on the best ways to approach these conditions, and not that there's a single best ways. We know so much, Sherry's favorite statement is many paths to recovery. So whether or not it's through therapy or through peer support or through supported employment or through medication, even of those wonderful practices, even among those, there's dozens of ways. And some of those medications have side effects. Some of the therapies don't resonate as much with certain individuals as others. And so, to Chuck's point, there's still not a sense of a best solution in terms of, when somebody has another medical condition or a certain type of cancer, there's paths, and they're really clearly lining themselves out now for practitioners, still evolving, but lining themselves up for individuals to make those very well-informed choices. And we are still kind of having to push that research along. and it's been delayed. And so I'm so excited whenever I get an outcomes article in my inbox, or when Sherry and I've studied peer supports in Georgia and the amazing outcomes that are forthcoming, and the more other partners, all of us and all over the country and the world are doing this work, it will be much more encouraging to folks too, so that they can carry that hope and really anticipate wellness and recovery.
And maybe I'd just say, though,
Yeah,
that
Chuck.
if the federal government Substance Abuse and Mental Health Services Administration has a survey that they do about drug use and health, and the number one reason people don't access care is because of stigma. They're embarrassed, or they don't understand if treatment will work. The number two reason goes back to your very first question. The second largest reason people don't seek treatment is they don't know how they're going to pay for it.
Can't afford it.
They can't afford it. And so that's why this conversation about essential health benefits and parity still remains so important, because that still is a huge obstacle for people.
And we know that there's millions of people in the country that have no health insurance or are underinsured with a huge deductible, and they don't seek any kind of care in a lot of cases because of the cost.
Yeah.
Right.
How much of this, not getting care has to do with maybe someone who tries something, whether it's a therapist or a medication, and it just doesn't work, and then they think, well, nothing's going to work.
Right. Yeah.
Is that an issue?
It's hopeless.
I think it is, yes.
Well, I think you hear a lot of people, right? Sometimes it takes a while to find the right combination of medications that actually work for you. And, it's not, we don't have DNA testing yet to know that, hey, if this medication for sure is going to work. And so sometimes people have to try lots of different things, and that sometimes takes a while, and you have to persevere. Also, the right combination of support services and therapies, and sometimes you just don't click with your therapist, or there's lots of other factors that come into play.
We sometimes have been treated like it's sort of a, that there's a silver bullet, right? And it's like magic. Mm-hmm. Just take your medication and everything will be okay. And regrettably for most of us, there isn't a silver bullet. There's a bunch of things that we need to do. It's why I keep talking about a journey, because it really is. It's larger than you go to the doctor every 3 months and get your prescription refilled and everything will be fine. It's so much more complicated than that, and behavioral health is so much more complicated than that for us. And as Wendy talked about earlier with the science, it's still definitly in progress.
And the one thing that I want to add as a complement to these points is that even when medications are prescribed and you find the right one that maybe quells anxiety or elevates your mood, many of them have significant side effects. And so we have to continuously talk about integrated health, whole health, because it's very frustrating for any individual who may already have diabetes, and then their medication, they read the side effects and it tells them that you may gain 20 to 40 pounds on this medication, or you're going to have these other side effects. So how do we say to individuals, we really need to work with you so that you have a good nutrition plan, that you have somebody supporting you with exercise, setting really manageable whole health goals, and having that other health care wrapped around this. And for state authorities, this is a real challenge because we don't administer general health, but it is so imperative to wellness because, we always laugh and say, why did it take us so long to figure out, the head's connected to the body? It's actually a neck. This has been one of our kind of running jokes in the work that Sherry and I've done about whole health, is you really have to kind of take an approach to sometimes a mental health or addiction condition, and you've got to be thinking, though, about all of the other mind, body, spirit parts of wellness that you have to bring together with that. And so health integration, we've not touched on tonight, but it is so crucial to the individual who's trying to be well.
So it's the health provider team, whether it's the health insurer or the actual physician, social worker, that needs to take this holistic approach here.
Absolutely.
Oh, everyone must.
Everyone.
It's a team.
Right.
Well, and there's some really compelling reasons for that to happen, right? If you look at people who have serious mental illnesses, they tend to have a lot of other health problems, and they die very young. And so from a systems perspective, we have an obligation to make sure that we do this. What's the use of somebody recovering if they're dead at 50, right? We don't want to see that happen. The other reason why this is really important is because people who have chronic health conditions and have a depression or an anxiety along with it, they're very expensive to the healthcare system, and their health outcomes aren't as good. So there's a lot of compelling reasons why we should be talking to each other and working collaboratively.
If you have a question, if you could go to the mics while we ask one more question of the panel, we'd love to hear from you. What role do employers have in ensuring that behavioral health benefits are robust and work very well?
Well, especially for people who are privately insured, right, this is a huge expense for employers to pay for this coverage. And I think one of the questions they want to be talking to their benefit managers about is, we're paying for this coverage, can people actually get in? It's been interesting in parts of the country, employers are actually leading the discussion around parity, around access, around network adequacy. And so I think, if you have private insurance and you're having a problem, you also need to talk to your human resources department to say, hey, we have this benefit, but I can't access it.
All right, let's hear from you folks. George.
Hi, thank you. Andy, good to see you again.
Thank you, George.
Settlement agreement, the consent order at the state. State's not going to make it. I don't think they have a chance in whatever. So what should the judge do to the Georgia Department of Behavioral Health and the state in order to ensure that we've got some state of compliance moving forward?
Wendy,
I don't feel like, I was about to say, I'm not sure I feel like I should answer that. It is our department's #1 priority to meet the settlement agreement. And
You're not making it, though.
well, I mean, we're feeling good about our progress. So I feel like I should say that, and then I should let others speak about
I don't have an opinion
what
about
should the
this.
state do. He said. So I'm going to refrain from that response.
Wendy, what has the state done to comply? Let's just go, and where are the areas that are maybe some gaps that
Right.
still need to be addressed?
So right now, most of the elements of the settlement agreement, we are in compliance for. So there's a couple of key areas. We are still working with individuals who have intellectual and developmental disabilities to be sure that the last individuals who have lived in institutions have safe, caring, supportive, integrated places to be. And so those pieces, and then supported housing, really just being sure that individuals have integrated housing supports in the community. Those are the 2 areas of focus during these few remaining months. So we have implemented a tremendous number of ACT services. We have really worked to develop community resources throughout the system to be sure that individuals have really good alternatives to institutional care. And we, I think, have been very excited about the lives we're seeing enriched by the settlement. So again, we are all pedaling very hard towards that goal, and it is our #1 commitment.
Chuck, you were about to say?
No, nothing.
Okay. Sherry, what did the settlement agreement mean to consumers? This is a 2010 settlement with the DOJ between the state and the Department of Justice.
The settlement agreement has been really important to us from the perspective of it infused, it it put a spotlight on mental health. It brought resources to mental health, which are imperative and need to hold and even increase. And so just those two things in and of itself is a positive thing. Having people openly recognize that there have been and there are serious challenges and working committedly toward remedying those is really important. There are still issues that are outstanding on the table, important issues that need to continue to be worked on and resolved. And it's always kind of a double-edged sword with regard to litigation, because it interferes with the ability to speak openly about things. It interferes with the ability to the ability to always have the feeling that everybody is working in good faith, because there's always this sort of litigation hanging over your heads. At the same time, sometimes it has to happen, and it had to happen here, and it has. And I believe that things are moving forward. I believe that there's still a ways to go.
John.
Over there. So bearing in mind the opioid crisis and everything, and that DBHDD put on a wonderful opioid learning thing going on over at Stone Mountain. It was wonderful.
Today and tomorrow.
What can be done in regards to the dual diagnosis in both the safety net settings and also in prisons?
Well, I mean, I think that the most important thing is to not look at any condition. You heard me speak about how important whole health is, to not look at any of these with singularity. So being sure that we really work to address what are the driving needs and what are the challenges for an individual that's kind of preventing them from recovery and wellness. And particularly in jails, I can't remember, jails, prisons, which?
The safety net settings and prisons.
Right, prisons. So particularly in prisons, we were just talking about the fabulous article. The state has implemented forensic peer supports, and we are working closely with our partners who certify and support certified peer specialists in their employment, and we are working to have certified peer specialists engage in those settings with individuals who are going to be transitioning back to communities, to get to know them, to build a relationship, to talk about recovery in those settings, and then to transition with those individuals into the community so that that support is seamless, and to really work with those individuals. Of course, that unfortunately is not Medicaid billable, but the state is putting resources, though, to this so that there is this meaningful transitional support. And so I think for me, it's about not having barriers and boundaries with certain conditions, whether that be addiction or mental illness or diabetes or pulmonary conditions, cardiac conditions, et cetera. Really the whole health perspective.
And with regard to peer support in the arena of supporting transitioning citizens with coming out of prisons, the Forensic Peer Mentoring Project that the state is working with the Georgia Mental Health Consumer Network on has been really important with supporting people who, many of the people that we work with have behavioral health concerns, mental health and substance use diagnoses. And people get supports that they need from people who have been there and done that. The forensic peer mentors are people that experience behavioral health concerns and have been in prison themselves, have had direct contact with the criminal justice system, so they know what it is. And they also know what it is to have experience with mental health and addictive disease challenges. And so they support people with transitioning into lives of recovery and wellness in the community. And so it is so important. We also, I spoke earlier about our warm lines, and there are certified peer specialists and certified addiction recovery empowerment specialists that work with people to provide, warm line peer supports over the telephone. And then we also have peer support wellness and respite centers across the state that support people with lives of recovery and wellness. So these various types of services, these are just a couple that I've mentioned, but they're so important because people, you learn what you live. So if you only knew a life of illness, of challenges with addictions, with illness of various varieties, and you go back to that lifestyle, you're going to continue to live that life all over again. But if you can find supports to get yourself out of that rut and to move on to a recovery and wellness perspective, there are many of us in this room that are living proof that you can do it. And with support, it makes all the difference in the world.
Yes.
Hi.
Hi.
My name is Colin. I'm the director of the Mental Health Student Coalition here at the Georgia Institute of Technology. Last semester, we unfortunately had a suicide on campus, which made very public news. And after working through that, I worked with faculty, administration, as well as other students. And we were lucky enough to establish $1 million fund for mental health initiatives here on campus. And I'm actually in charge of allocating that money, and right now, of course, we are working.
Excellent.
Of course, we're working with Campus Resources, Counseling Center, Psychiatry, and I am currently in the process of hosting a collegiate mental health summit a year from now to bring colleges to engage in a discussion about mental health. But my question that I have today is, I have $1 million, what do I do with it on this college campus? Really.
Me without a card in my pocket. When do you know it?
Our names are in the program, Colin. Thank you for being here.
Is the money supposed to be contained at Georgia Tech then, in terms of services at Georgia Tech?
So actually, there's no rules technically about it. I'm on the committee that oversees it, and the idea is that at the end of the day, it has to benefit Georgia Tech students because that's what it was established for.
Sure.
But the way that we do that is completely up to the interpretation who submits the bill.
Sure.
Any thoughts?
Well, I think that it's always a great idea to bring people together. So having focus groups with people to bring together ideas from your community is, I find, always an excellent way to start. Then bringing in people who know something about the behavioral health arena and getting some guidance and consult and ideas about what can be, what could you do, what might it look like, and look to other institutions similar to yours who have strong, say, behavioral health programs, and look at innovative things that they're doing on campuses are all really good ideas, tried and true and good ideas.
And I know there's several campuses who've actually instituted these programs, and some of them have been then replicated at multiple universities. So I think even though I don't have the names handy, I bet a bunch of people here do now that they've met you, Colin. And I think, if we want to exchange information later, I can give you some resources. The one thing I think that's maybe not written a lot about yet, but in Georgia and in a few other states, we've started a targeted certified peer specialist program where individuals with lived experience like Sherry and many others in this room tonight have been trained, and they're young. So their age is 18 to 26. And so for me, it's also whether or not you tap into some of our resources at the state to learn about where some of those peers live and work. There are many other people with lived experience who I think are just beacons every time you do policy planning or do this type of implementation. The more you hear from the voices who've walked this journey and what helped them, and then start to build from those foundations, more the better. I'm so excited for you and for the students. Yeah. Congratulations. Yeah.
Thank you so much.
Yes.
Georgia Tech Master's Program graduate. And I've developed a whole system to rapidly decode how come people's behavior, their instinctive reactions, lead to issues that they would not really want to have in their life or other people would not want to have, including addiction issues, cravings issues, including the underpinning of terrorist, where the instinctive reaction is coming from. So I would love to do some research with you all on this very subject. My transformation work started back in 1987 with a program called STAR, and we went into issues starting at conception through birth process up to age 13, and a lot of the areas of transpersonal psychology. And Stan Groff was a major influencer in my life in his books, starting with Beyond the Brain and all that. Holotropic breath work, things to get people into transformative capabilities within themselves. And I'm asking, actually, where in Georgia are there governmental groups or peer counselor? In fact, my niece has been a peer counselor trained here in Georgia for 20 years and has done very well up in Virginia with that now. So I'm wonderfully happy about that program. But where are we getting some of the breakthrough technologies being looked at that are not medical model? It's more of a transpersonal model that somebody like me in the work that I've done can get into and help out with.
Well, the work is certainly being done and thought about and generated from people with lived experience and our allies.
Right. I've helped people drop cravings from chocolate to crystal meth to deal with bipolar issues and a variety of other things, looking at it from a whole different viewpoint of how come this has been happening in their lives. Not their fault, it's part of their uniqueness, but part of it is, where is the innovative work being done here in Georgia?
I'm not sure I can say for sure where. I mean, I think it's happening in a lot of spaces. And then, but I think usually we're on the recipient end, kind of once that stuff is kind of bundled up and done, at least from my policy perspective. So
I can certainly,
I can't answer that.
I can certainly say that there's innovative work being done in the recovery and wellness arena by the Georgia Mental Health Consumer Network, by the Georgia Council on Substance Abuse, by the Georgia Parent Support Network, and other such organizations.
The areas, those of us like me who is not a healthcare professional, I mean, I majored in physics and operations research and statistics and business process reengineering and organizational things. And so that kind of a background brings up more opportunity, actually, for, like Stan Groff has talked about, there's no ideology to mental health issues. Unlike chickenpox, you can say, oh, this is chickenpox and this is how we treat it. That doesn't happen in mental health.
I can say that, and we need to move on to another question, but I can say that some of the most innovative things are happening in this state. And Sherry's work and others' work, it doesn't, I mean, the idea of peer support is something that we really developed here in Georgia, and we've done a tremendous job on that.
Yes.
Yes, ma'am.
Thank you.
Yes.
Good evening. I'm a child and an adult psychiatrist working here in Atlanta. And part of work that I do is on the street medicine team, where we actually go to the street and treat people who are street homeless with physical and mental health issues. So I know there's a housing first policy here in Georgia, because we can all agree that having stable housing is important as part of a whole health model. But I still find the barriers to be extremely stringent. People need birth certificates, social security cards, things that I've never needed to rent an apartment. So I'm just wondering why, I guess, from a policy point of view, is that needed if we want to be able, if we know that it not only saves lives, but also costs the state less money.
I think I will just add that a lot of this depends on the funding streams, and a lot of the federal housing funds and other things kind of have rules attached to them. I mean, all the places and spaces that we leverage funds from have certain expectations, and so sometimes those types of things get laid in based on federal fund sources or other fund sources. So not knowing kind of which programmatic line you're talking about, I can at least though say that. The other thing is from a state administrator's perspective, we're frequently trying to study these outcomes and do the monitoring we're thinking about, and reviewing individuals and where they're getting services and needing to know a little bit more information to be sure that we're also looking at where individuals are getting maybe therapy services or peer support services, or where they're being hospitalized. So sometimes basic identifying information is needed from that perspective, but it's a conundrum, I know.
Chuck, along with her question, do states that have expanded Medicaid, have they had more success in bringing the homeless into a care system?
So some states like New York have, kind of coupled their Medicaid expansion with a huge investment in housing first, right? Recognizing that all the health care in the world isn't going to help if you don't have a stable place to live. Right. So some states have been very thoughtful about trying to weave those things together, and then using, having an investment of money to do that. I think the other part of your question, which I think is really important, is how do we reduce barriers? And our systems over the years have found so many ways to make it difficult for people to enter care. Not just some of the document, but in most public mental health systems, you have to fill out so many forms to enter care, and none of that information, pardon me, Wendy, most of it isn't necessary. Right. It's not really necessary. Right. And so we're a big fan of, can't we just make it simpler? Why do we have to make everything so complicated?
Yes, ma'am.
First of all, I'd like to thank you all for a very interesting and informative discussion this evening. And secondly, I would like to expand this conversation a little bit further. It's been greatly focused on the state. Maybe that was the intent. But thinking more nationally and globally, I have often thought how there are so many individuals in this world, in this nation, being negatively impacted mentally by trauma, abuse, lack of job, political turmoil, war, immigration experiences, which if they have had to go through camps and may be there for years at a time. To me, the mental health problems of this world are growing exponentially. And is there any hope for the human population to come past that?
Always hope.
Certainly,
good question.
Having systems that are sensitive to the broader context of trauma is something that is very important and imperative, because so many of us experience trauma in various forms, from childhood through 15 minutes ago or whatever. And then when you talk about just all the various examples that you gave across the world that are, one traumatic event after another, and we have systems that unfortunately in their practices then re-traumatize people that are already traumatized, And so efforts to be able to have care, treatment systems that are oriented and focus on trauma and supporting people through trauma difficulties and trying to come out the other side whole is really important. And it's work that we're doing here in Georgia but it's also being done across the country as well, and is a focus also of a lot of peer work that's being done as well.
Well, I know that's a major effort, but it just seems like the number of individuals impacted is astronomical, and progress can be made one person at a time. So it's a challenge. It's really a challenge. So I would like to credit the Carter Center for every effort you make on the behalf of those individuals who need it.
Indeed, indeed.
Yes, we have time for these last questions. Go for it.
Hi, I'm Jewel Gooding with Executive Director of Mental Health America of Georgia. And I wanted to just kind of go back to, you made a statement, Chuck, I believe, in regards to those who might be on private insurance and understanding what that conversation looks like and who should be leading that conversation. But, you know, we do look at our public mental health system, but also recognizing, you know, maybe as a state, what are some thoughts or ideas that Georgia could do that you, in your experience, you have seen other states be successful with, particularly with our same structure, that can identify how can we have that conversation so that, you know, access is more readily available for those who have third-party insurance, that not only access, but, you know, a reduction of surprise billing, and even looking at, you know, healthcare overall, but particularly mental health care, and how that's being provided to many employers, and even looking at the structure of it. So you maybe only have 10 sessions, and then that's it for the whole year. And honestly speaking, when you're working with someone with mental health challenges or mental illness, most times 10 sessions is just enough to start opening that person up. And then at that point, you're now having to discharge until next year. So just some thoughts of maybe what
Well, I think this goes back to the beginning of the conversation, right, about parity. And in that instance, right, you know, there's different kind of limitations, the ones that you can count. So if there are visit limits on mental health or substance use, are there comparable visit limits on the, you know, medical surgical side? You know, the other, you know, the bigger question that you're asking, right, is how do we get our state interested in enforcing this? And there's really two potential routes. One is your state insurance commissioner, because they're the people who oversee insurance in your state. The other potential is your attorney general. Really, I think New York is the only state that has seen kind of the attorney general get really active. But you know, the federal government has been spent a lot of time over the last year working with insurance commissioners, helping them understand, you know, how to enforce parity. And if you follow up with me, I can put you in touch with one of my staff members who, you know, kind of did a lot of this work on behalf of the federal government. We can get you some resources.
Thank you.
Yes, ma'am.
Where's the stool?
Sorry. Could you?
That was great.
No apologies needed.
Could you address the importance of young people staying on their parents' insurance to address eating disorders in particular?
So that, I will say, that's one of the benefits that have been very popular about the Affordable Care Act was individuals being able to stay on their parents' insurance to 26, and that's been a huge win for families. And but specific to the eating disorder condition, I can't speak to how private insurance is covering or not covering that very well, so I'm looking to my peers.
Well, it's covering. I have a granddaughter, and she, of course, is just out of college and just starting in a new job, and she's facing paying for care for her eating disorder, and that's a young person's, most of the time, that's a young person's issue. And it can be very serious. So I just wanted to say that is one part of the health issue that is not really being understood as to how dangerous it is. And frequently young people do not know what to do.
And it is so intertwined with holistic health. You know, a good mental health program is not a sole solution for an eating disorder. Again, nutrition and, you know, the body image work and healthy exercise and, you know, heart conditions, right. So there's so much that is intertwined with that from a holistic health perspective. And it's a challenge for young people to try to pay their own deductibles when they get a job, and it is a steep climb. Again, I go back to stigma, and we have to be talking to legislators and administrators about these benefits and how much we can gain from good treatment and recovery support. Yeah, thank you.
Last question, yes.
So we spoke about mental health and substance abuse parity and Medicaid and private insurance. How does any of this relate to the care being provided to veterans that receive care from the VA?
So the Veterans Administration, again, I'll just kind of do a quick prelude. They have their own health care plan. Right. And in many cases, those are delivered by individuals who work in that system. But more and more, there's been some opportunities for outsourcing and accessing services outside of that system. That being said, they are struggling, I think, with a behavioral health workforce, just like everyone else is. And, you know, Andy, we were talking about the study earlier that's been going on about behavioral health care workforce. And in Georgia, you know, we have 159 counties. 150 of them have some portion designated by the feds as a behavioral health shortage area. And so the VA is struggling, just like community mental health centers, just like the private sector, finding all of the individuals that they need. But I think we can say a big woohoo because they're hiring peers. And really, we've worked with the Veterans Administration for many years in Georgia and then nationally to try to help the workforce by infusing individuals who are certified and have lived experience on how to promote health and wellness and recovery for individuals when they can't see a doc in the system, or they can't get to a nurse practitioner or a therapist in that system. And in Georgia, the VA is actually recognizes the Georgia Mental Health Consumer Network curriculum as one of their national certifying entities. And so we have a lot of interaction with you know, individuals working for the VA who are certified peer specialists. But that's kind of the one place that I think we intertwine.
One thing that the VA does.
What would y'all like to add?
Yeah, one thing that the VA is emphasizing is telemedicine and telepsychiatry, and what I'm told is that it really is a great thing. This movement toward bringing behavioral health and therapy through technology.
Yes. Right. I have experience with the VA providing telemedicine, but when they outsource into the community service boards, they do not cover telemedicine for veterans.
One thing that telemedicine does not do well in this state is reimburse providers. And that's something we all can work on in terms of advocacy. We just don't do a very private insurance and other insurance, we don't do as well as we could.
Right. Thank you.
Well, why don't we give our panelists a great hand? They did tremendous work.
Thank you. My name is Eve Bird, the director of the mental health program here at the Carter Center. And on behalf of the Carter Center, the mental health program, and former First Lady Rosalind Carter, I really want to thank you, Chuck, and Sherry, and Wendy, and Andy for your long-term partnership and all that you give every day. We have all made great progress, as we talked about today, but clearly have a lot of more work to do. And I also want to thank everybody that came out this evening, because it's with your advocacy and your understanding and your interest in learning more and how you can participate is where we're really going to make things happen. We still have a lot to do on behalf of persons with mental health and behavioral health challenges. So thank you all for coming out this evening to Conversations at the Carter Center. Wish you a great evening. Come back. I encourage you to come by and see this wonderful work of Matt. It is just fabulous, and I know you can't see it from your seats, so please stop by on your way out.